Hi, everyone. Welcome to this month's Visual Sonics featured publication audio recording. Today, I have Dr. Amparo Ruiz from the Center of Biomedical Imaging, Department of Radiology at New York University. Dr. Ruiz will be presenting the accuracy of ultrasound-guided versus landmark-guided intra-articular injection for rat knee joints. This work was recently published in the Ultrasound Medical Biology Journal. And with that, I'll turn it over to Dr. Ruiz.
So hello, my name is Amparo Ruiz, and I'm an assistant professor at the Department of Radiology at NYU. I'm also the co-director of the Osteoarthritis Lab for Experimental Imaging. So today I'm going to present the work that was published in Ultrasound in Medicine and Biology, where we evaluate the accuracy of ultrasound-guided injections versus anatomical landmark-guided injections in rat knee joints. So our research is focused in knee osteoarthritis, which is the most common degenerative disease. As today, there are not known effective treatment or disease-modifying drugs for the disease. On the other hand, there are several putative drugs that are currently under development preclinically. The majority are administered locally in the articular capsule. However, most of these studies rely on anatomical landmark-guided injections for intra-articular delivery. That require highly trained personnel, and they cannot be validated since they poorly rely on the expertise of the injector. Accuracy of intra-articular delivery plays an important role in the success of drug development in preclinical studies, and we believe that ultrasound-guided injections can help to increase accuracy of the injection. The objectives of our work were to first develop an ultrasound-guided method to inject intra-articularly in knee rats that can be used by untrained and experienced personnel, and then evaluate the accuracy of these ultrasound-guided injections using our method versus the traditional anatomical landmark-guided injections. So we develop and validate a method using the Vivo 3100 system. This method involved basically 3 steps. First, the animal positioning, then the transducer and the needle positioning, and finally, the intra-articular injection. So I'm going to talk first a little bit about the animal positioning. And for that, we place the animal in a dorsal position on the heated stage. And then we flex the limbs and externally rotate by 45 degrees. We use a gauze pad under each bent limb to avoid excessive knee flexion. And as you can see in this third image, we immobilize this positioning with surgical tape. Position of the stage is critical to ensure success of the injection, and it is worth it to take the time to achieve proper positioning. Once secured this positioning, we tilted the stage to position the femur parallel to the transducer and then approximately perpendicularly to the direction of the injection, as you can see in the last image. So for the transducer, we use a 40 megahertz transducer. That is the picture in the picture, and this is the one that is suitable for our animals. Before the injection, we place the transducer parallel to the femur and above the flexed knee joint, as is shown in the picture on the left. In this plane, we were able to localize the patellar tendon ligament that is showing like a dark band in the ultrasound image. Then we rotate the transducer 90 degrees, as is shown in the left picture, to the patellar tendon. In this plane, we are able to identify the deep V shape of the trochlear cartilage as a dark band. Our target to place the needle, it was right about the trochlear cartilage. That way, we can ensure delivery inside of the articular joint. The needle was inserted laterally to the patellar tendon by using the lateral portal. In the picture on the left, you'll see where the needle trajectory will be once the needle is positioning in the rack. So with the knee held in flexion, the patella does not inhibit the acoustic access and expose the trochlear cartilage, but that is our target. We choose this needle entry point and the transducer orientation because the insonating beam is approximately perpendicular to the needle trajectory, then displays the needle all the time as a specular reflector. As you can see in the ultrasound image, the line, the specular reflector is the needle trajectory, And then we can also see the tip of the needle in the intra-articular capsule. So then last, we will follow intra-articular injection, and what you get to see step by step using this method. So for the injections, we recommend using longer needles because they help to visualize the needle trajectory. Specifically for our study, we use a 1.5-inch needle attached to a Hamilton syringe because we ensure the precise volume. And then we constantly monitor the plane of the needle because it shows like an specular reflector. You can see here in the arrows are marked and the needle. So once the tip of the needle was detected in the intra-articular capsule, we could start injecting the liquid, and we get to see a little bit of bubbles marked with the arrow. And then after injecting, we can see an expansion of the intra-articular cavity. So here in a real-time video, again, you start seeing the needle as a line on the right. And then when the tip is positioning in the right position, here we can start injecting the liquid. You see increase on the cavity, on the volume of the cavity. So with our method, we were able to visualize the needle in all cases. Always the needle, always the tip, and then you always get to see the expansion of the cavity, or even the bubbles at the end of the injection. However, we are a group that works with contrast agent and different imaging modalities. So we validate the accuracy of our injections with a secondary imaging modality. So when the material that we injected was labeled with a fluorophore, we were able to localize the distribution of this imaging agent with near to infrared optical imaging. So 6 hours after injection, we could detect the imaging agents distributed in the joint capsule, as you can see in the after injection image. For failed injections, the imaging agents were almost eliminated from the capsule at that time. So it's easy to discriminate between success and failure. When epромide was injected, we used CT to verify the injection, and we could detect accumulation of the contrast agent in the cavity, in the articular cavity, as depicted with the asterisk. We also use a gadolinium-based contrast agent, and for that we detect them with magnetic resonance, and we saw accumulation of the contrast agent with the, you can see here with the arrows after injecting. There's an increase on the volume in the inside of the articular capsule. And a failed injection shows the contrast agent out of the capsule. So then we compare the success of intra-articular injections by using both methods, landmark guided injections and our method, ultrasound-guided injection. And for that, we performed for the landmark guided injections, 50 injections. It were bilateral injections on 25 animals, and 46 for the ultrasound guided injections. In both cases, all injections were performed by a single injector. In the case of the landmark guided injections, resident orthopedic surgery with 3 years experience performed all the injections. And for the ultrasound guided, the injector has no previous experience injecting at all. And both got to practice with 2 animals before counting for the success of injection. So overall, we obtained a 58% success rate for landmark guided injections and 89% for the ultrasound guided injection, which is significantly higher. For an early group of 10 animals, so there were 20 injections, we obtained for a 50% success rate for the landmark guided injections and an 85% ultrasound guided injection, which is a really high accuracy for an experienced injector using this method for the first time. For the second round of injections, so it would be the rest of the animals remaining, we found that an increased rate of success for both methods. from 50% to 63% for the landmark-guided injections, and from 85% to 92% for the ultrasound-guided injections. In any case, accuracy of injection was always higher for the ultrasound-guided injections, and in our hands, more practice led to almost 100% accuracy using our ultrasound-guided method. So we can conclude that ultrasound-guided intra-articular injections have higher accuracy than traditional landmark-guided injections. I didn't mention it in the presentation, but they also require less attempts than the landmark-guided injection, which often require repositioning of the needle, often more than one time for injection. This is important because it reduces overall the damage created that can enhance undesired inflammatory signaling. So intra-articular injections using our ultrasound method do not require previous experience, since you can monitor the needle in real time all the time, although the accuracy can improve somehow with experience. And of course, this method can be applied to smaller rodents like mice by using a higher frequency transducer. I would like to remark that increasing the accuracy of intra-articular delivery of putative drugs can highly affect the success of drug development in preclinical studies, since it reduces variability, increased reproducibility, and of course, it minimizes the number of animals required for these studies. I would like to thank Visual Sonics for allowing me to present this work. Thanks to all my collaborators and of course to our funding sources, and thank you.